السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بالجميع. حياكم الله في الجزء الثاني من كورس اليوفيتس مع الدكتور عبد السلام محمد دياب. دكتور عبد السلام استشاري طب وجراحة العيون، تخصص دقيق في الميديكال ريتن اند يوفيتس. واليوم إن شاء الله هيكلمنا عن البراكتيكال تيبس in Uveitis Workup and Treatment. تفضل دكتور عبد السلام، كلنا أذان صغير.
شكرا جزيلا دكتور عمرو. السلام عليكم ورحمة الله ومساء الخير على الجميع. بتكلم اليوم، هي تعتبر continuation of the previous lecture اللي هي approach to uveitis patient. نيجي على الورك اب. احنا تكلمنا على الهيستوري والفيزيكال اكزامينيشن، بعدها ندخل على الاوفثالميك ايميجينج اند فانكشنال تيستس. وهذه الاوفثالميك ايميجينج اند فانكشنال تيستس بتساعدنا كثير في الدياجنوسيس اوف يوفيتس. ممكن تساعدنا to confirm the diagnosis of uveitis أو in monitoring the patient response to therapy. ومرات تعطينا information not obtainable from biomicroscopy or fundus examination، زي ما بنشوف في أمثلة لاحقا. طبعا في عندنا عدد من الأوفثالميك ايميجينج اللي ممكن نستخدمها في اليوفيتس، زي الكالر فوتوغرافي، زي الاوبتيكال كوهيرنس توموغرافي الاو سي تي، او الاو سي تي انجيوغرافي، الفندس اوتوفلوريسنس، فندس فلوريسين انجيوغرافي، اندوسيانين جرين angiography والبي سكان، و sometimes we need to do some invasive tests. بنعرج على هذه الايميجينج موداليتيز، وبنبين ان شاء الله كيف ممكن تساعدنا في الدياجنوسيس. بالنسبه للكالر فوتوغرافي، طبعا الكالر فوتوغرافي ممكن يساعدنا في الانتيرو سيجمنت ساينز وفي البوستيرو سيجمنت، يعني ممكن نطلب سليت لامب فوتوغرافي او كالر فندس فوتو. وعادة هذه نسويها تو دوكيومنت الليجن سايز او الكالر او اللوكيشن او المورفولوجيك كاركترستكس، عشان تساعدنا فيما بعد في الفولو اب of the patient to see the response of treatment, or if there is any progression or regression of the lesions. مثلا this patient, he has this posterior pole lesion which looks like choroidal granuloma. We investigated him. We found him to have high positive PPD. We treated him with anti-TB, and with treatment we repeated the color fundus photo. It shows clearly the regression of this lesion, يعني it decreases in size, and by the end of the treatment you can see that this lesion is totally resolved and disappeared. بالنسبة للoptical coherence tomography, which is very important in uveitis workup، طبعا بيساعدنا في عدة اتجاهات أو في عدة مراحل من تشخيص اليوفيتس. ممكن يساعدنا في to diagnose اليوفيتيك macular edema. طبعا اليوفيتيك macular edema is very common in uveitis, and it can complicate any type of uveitis. So the presence of uveitic or if macular edema in uveitis, it doesn't mean that this is posterior uveitis or panuveitis. Macular edema can come even with anterior uveitis. So optical or OCT is a must in the workup of any uveitis. طبعا ال OCT ممكن يساعدنا to diagnose lesions like choroidal neovascular membrane, or if there is serous retinal detachment, or also, which is very important, to differentiate between some chorioretinal lesions that look like similar to each other. Many chorioretinal lesions, as we will see, are very similar on clinical examination, But if we do OCT, we can see some differentiating features that can help us to diagnose each lesion with certain accuracy. طبعا في also some characteristic OCT findings that we should keep them in mind, because if you see these OCT pictures, you should think about specific diagnosis. For example, if you see this type of serous detachments, which look like that it has two layers, an outer layer, or we call it submembrane serous detachment, because it occurs outer to the external limiting membrane. وفي supra membrane detachment. هذا type of serous detachment we call it bacillary layer detachment. وبالhistopathology it was found to be splitting or separation between inner and outer segment of photoreceptors. If you see this pattern of OCT, you should think about, which is which uveitic entity that come with this OCT picture. Anyone can write or can suggest any diagnosis?
الزملاء ممكن طبعا على الشات بوكس نبعت الأجوبة للأسئلة، من باب إنه المحاضرة تكون مور انتراكتيف يعني، ونكون كلنا متفاعلين مع الدكتور عبد السلام إن شاء الله. السؤال مرة ثانية دكتور بعد إذنك.
If you see this in a uveitic entity, this type or this pattern of OCT, you should think about certain or specific uveitic diagnosis. What is it?
أحد الزملاء كتب VKH.
Excellent. So this is very suggestive of acute VKH, okay? This is called bacillary layer detachment. It is very common in the acute phase of VKH. Also another typical OCT findings in acute VKH اللي هو يجي multiple pockets of both serous detachment and bacillary detachment. If you see this OCT also, you should think about acute VKH. And also this, which is also typical for acute VKH, بيكون في serous detachment with retinal pigment epithelium undulation or folding. Also, the OCT can help us to confirm the clinical diagnosis. If we see this the picture, which is blacoid-like lesion in a patient who present with sudden drop of vision, you should think about what? Anyone? I think we went through it in the last lecture.
This is syphilis كتب.
Excellent. So you should think about placoid syphilitic chorioretinitis, and OCT can confirm our diagnosis, because the OCT in acute syphilitic chorioretinitis has this specific pattern with loss of the ellipsoid zone, or the outer segment and inner segment junction, with these pyramidal protrusions in the retinal pigment epithelium. The OCT in this case can confirm this diagnosis. And even sometimes some patient came like this patient. He come with also a sudden drop of vision in the right eye. And clinically, it is more or less normal. You cannot see specific pathology. But when we did OCT, we saw a very similar OCT pattern with this syphilitic OCT with loss of the outer retinal layer and these pyramidal protrusions in the retinal pigment epithelium. And this is also highly suggestive of another entity of syphilitic chorioretinitis, which is called syphilitic outer retinopathy, in which the clinical picture almost look normal, but when you do OCT, you will find loss of the outer retinal layer, especially the ellipsoid zone, with these retinal pigment epithelium lesions. So OCT can be very helpful in some vague uveitic entities, and even OCT can be useful in the follow-up of these patients, because after treatment, this OCT should be improved. And this is the OCT of the same patient. You can see the complete restoration of the ellipsoid zone and the disappearance of these retinal pigment epithelium lesions. Also, OCT can help us to differentiate between similar chorioretinal lesions. If you see to these three retinal lesions, they are almost similar to each other, and you cannot differentiate between them depending only on the clinical examination, and you have a lot of differential diagnosis. But if you do OCT, you can see clearly that each one has a specific OCT pattern. This first case or first lesion has this retinal involvement with also choroidal involvement and thickening. So it is a pattern of chorioretinitis, which is highly suggestive of what?
Toxoplasmosis?
Toxoplasmosis, excellent. While this, you can see this lesion, it is coming from the choroid and protrude or pushing the retinal pigment epithelium and involving the whole retina, and even also go through the retina to the vitreous. This sign is called rain cloud sign أو السحابة الممطرة. هذه if you see this OCT picture, you should think about candida retinitis. Okay, and this lesion, you can see that it involves only the retina with almost preservation of the choroid, and retinal pigment epithelium is intact, and this is very typical of viral retinitis, and sometimes even Behçet retinitis can come with only retinal involvement. كمان ال OCT can help us to differentiate between, if you are in doubt, is this lesion is choroidal lesion or retinal lesion, because this lesion is covered or obscured by blood. But you cannot judge depending on the clinical picture, is it retinitis or is it choroidal lesion? But if you do OCT, you can clearly see that there is a choroidal lesion with subretinal hemorrhage. So OCT is very helpful in uveitis workup, especially posterior uveitis. طبعا P type of the OCT, which is now commonly implicated or commonly used, اللي هو enhanced depth imaging OCT. This pattern of OCT provides deeper tissue penetration than standard OCT, وهو useful to assess the structural changes in the choroid. طبعا هذا commonly used في السنترال سيرس retinopathy. and الأذر اللي يسموها الباكي كورويدوباثي اللي يكون فيها thickened choroid. طبعا في some باكي كورويد uveitic entities, especially ال VKH في الacute stage يكون الكورويد is very thick. if you do enhanced depth imaging OCT, you can see clearly that the choroid is thickened here. And also this enhanced depth OCT can help us in the follow-up of the patient after treatment. You can see here that after treatment, the choroidal thickness decrease and it becomes normal with time. طبعا عندنا كمان ال OCT angiography. ال OCT angiography, it is also a technology that produces structural imaging of perfused vessels in ocular tissue. يعني هو imaging modality that showed us ال perfused vessels. فهو more or less يشبه الفلوريسين angiography. طبعا في some differences. فهو non-invasive modality to assess الريتنا and الكورويدال vasculature. وطبعا أحيانا باليوفيتس it can be very helpful, especially to differentiate between inflammatory lesions from choroidal neovascularization, because sometimes they look like each other in clinical examination. For example, if you see these two eyes, this lesion, you cannot tell depending on the OCT, the standard OCT, whether this is choroidal neovascular membrane or it is just an inflammatory lesion. But if we do the OCT angiography, you can see here that there is a vascular network here, which is highly suggestive of choroidal neovascular membrane, while here there is no vascular network, just enhanced reflectance here, maybe because of overlying thin retinal pigment epithelium. In this case, this is choroidal neovascular membrane, and here it is just inflammatory subretinal deposits. And طبعا this will help us in the management, because the management will be totally different between these two cases. If you depend just on the OCT and sometimes the clinical picture, you can think it is just an inflammatory lesion and treat the patient without giving him anti-VEGF, and then he can progress to scarring of the macula. وفي عندنا كمان another important modality في ال Uveitis workup اللي هو الفندس autofluorescence. الفندس autofluorescence طبعا نعرفه it maps the fluorescent property of lipofuscin, which is a product of retinal proteins within the retinal pigment epithelium. طبعا it is useful in evaluating patients with posterior uveitis that involves the outer retina or retinal pigment epithelium or the inner choroid. فهو مفيد في الحالات اللي يكون الليجن فيها at the level of the photoreceptor or the retinal pigment epithelium or the inner choroid. Generally, طبعا not always, but generally, hyperautofluorescence means there is active uveitic process, while hypoautofluorescence means that this lesion is inactive. بس طبعا في استثناءات ممكن بعدين نتعرض لها في محاضرات أخرى. وطبعا فوائد الاوتوفلوريسنس كثيرة. يعني مثلا if we see this lesion, you can see that there is something abnormal here, although it is a subtle change here. But if you do autofluorescence, you can see clearly and be sure that there is certain pathology in this region, because there is hyperautofluorescence involving this area. Autofluorescence here enhances the view and borders of lesions. كمان if this patient he came with sudden drop of vision in the right eye, if you compare both eyes, you cannot see much difference in the clinical picture or in the color fundus photo. But if you do the autofluorescence, you can see clearly that there is some hyper-autofluorescent dots or spots involving the posterior pole of the right eye. In this example, the autofluorescent can detect subtle subclinical changes. And not only this, sometimes the autofluorescent can help you to differentiate between active and inactive lesions. If you can see this, especially in the serpiginous chorioretinitis, because the active lesion usually emanate or starts from the border of the inactive lesion. And sometimes at the early stages, you cannot differentiate between them clinically. So you cannot tell whether the patient needs treatment or these lesions are inactive and he doesn't need treatment. But if you do the autofluorescent, you can see that there are certainly some lesions that are hyper autofluorescent and active and needs treatment. So autofluorescent can differentiate active and inactive lesions. Fluorescein angiography also is important modality of investigation and workup in uveitis, especially in retinal vasculitis. It can show us leakage or ischemia or neovascularization. Also, it can show us if there is any optic nerve inflammation with capillary leakage. It can detect macular edema. If there is choroidal or retinal neovascularization, and also some white dot syndromes have characteristic appearance on fluorescein angiography. Also, we have some characteristic fluorescein angiography. If you see them, you should suspect also certain uveitic entities. This picture, which is called pinpoint leakage or starry sky appearance, زي السماء المليئة بالنجوم مع hyperemic disc. This is also highly suggestive of acute VKH. While if you see this pattern of leakage, بيكون diffuse capillary leakage with a pattern called fern leaf leakage، يعني زي أوراق ما أعرف السرخس ما أعرف إيش. المهم إنه لما تشوفها هذه diffuse all the capillaries in the retina are leaking, you should think about which uveitis. Anyone know?
الزملاء. Diffuse capillary leakage, fern leaf leakage, suggestive which type of uveitis?
نعطيكم خيارات. هل تي بي، ساركويد، بهجت؟ في أي إجابات يا دكتور؟
ما فيش خالص، صعب السؤال. في أحد الزملاء يقول بهجت. في واحد الآن جاوب.
Yes, excellent. So if you see this diffuse capillary leakage, you should think of بهجت uveitis. وطبعا في retinal vasculitis it is a must, because depending on the clinical picture you cannot tell if this vasculitis is ischemic or no, because there is no obvious new vessels that can tell you there is ischemia. But if you do the fluorescein angiography, you can see clearly that there is significant ischemia in this type of uveitis. This is occlusive vasculitis. طبعا في hint في الclinical picture here. If you see vascular leakage with perivascular hemorrhages, these perivascular hemorrhages are indicative of ischemia. Okay, فhemorrhagic vasculitis usually it is ischemic in nature. But طبعا to confirm this you should do fluorescein angiography. Endocyanin grain angiography, which is not commonly used because the dye is not commonly available even in our institute. And many times it is not available, but it is very helpful in diseases of the choroid especially, and in the granulomatous type of uveitis. فممكن تورينا السطل lesions. If you see this picture, there is some disc hyperemia, but you cannot tell that there is a certain pathology. But if you do the endocyanin grain, you can clearly see multiple hypocyanescent or hypofluorescent dots, which are suggestive of multiple choroidal granulomas. وطبعا البي سكان كمان can be used especially in the presence of opaque media like in posterior synechia and inflammatory membrane covering the lens, or in cataractous lens. It can tell you a lot about the vitreous, if there is vitreous opacities or choroidal thickening or retinal detachment, or if there is cyclitic membrane. Or if there is posterior scleritis with the typical T sign. And also UBM or ultrasound by microscopy can be helpful to assess the anterior segment in cases of uveitis, to assess the ciliary body, especially in chronic hypotony. It can show us that there is ciliary body atrophy. Or in cases with resistant uveitis, especially post-op, it can be merely or just because of malpositioning of the IOL, which is called uveitis glaucoma hyphema syndrome. وطبعا احيانا نحتاج نسوي some invasive ocular tests, انه ناخذ fluid for analysis or for culture and sensitivity, or for PCR polymerase chain reaction, or for cytology and histopathology in cases of masquerade syndrome if we suspect malignancy. And in rare cases you need to take chorioretinal biopsy or even scleral biopsy. نجي لللابراتوري ورك اب. laboratory workup طبعا, as we said in the previous lecture, the most important في uveitis evaluation, medical history and review of system, and detailed ophthalmic and general physical examination. If you do this well, then you can do a good differential diagnosis, and after that you can do specific laboratory tests depending on your clinical evaluation and your differential diagnosis. The approach or the trend of shotgun uveitic workup, which means any uveitis or any uveitic disease, you do every uveitis workup and every investigation. This is a wrong approach. So ordering laboratory tests without consideration of a reasonable differential diagnosis is expensive and even may yield confusing results. Again and again, laboratory testing is not a substitute for a thorough hands-on clinical evaluation. لكن بالتأكيد laboratory workup can help us in certain uveitic entities. طبعا many patients will require only a few diagnostic tests. بالنسبة what should we order? most uveitis specialists do recommend syphilis testing. Why? Because syphilis, we call it a great imitator أو a great mimicker, بمعنى إنه it can present with any type of uveitis. It can present with anterior uveitis, with panuveitis, with vitritis, even with the endophthalmitis-like picture. We saw cases, we thought it is endophthalmitis, and at the end, it turned to be syphilitic uveitis. Any uveitis workup should include syphilis screening. In addition, in patient with occult syphilis, if you treat him with immunosuppressive or systemic steroids, this can yield disastrous results and can aggravate the systemic syphilis complications. Also, if you are planning to do systemic treatments, especially steroids, you should also do TB screening. So you should roll out tuberculosis. How? You should do PPD, purified protein derivative test, or tuberculin skin test, chest radiograph, and sometimes the quantiferon blood test for TB. when not to test, متى لا يكون هناك ضرورة لطلب فحوصات. If you are treating simple anterior uveitis, زي إيش؟ مثلا first episode uveitis, especially if unilateral acute non-granulomatous. This type of uveitis usually doesn't need workup, so you can treat him. And then if recurrent, you can consider workup, or if you see any other ocular or extraocular signs that suggest like systemic disease or specific uveitic syndrome, then you can work up this patient. Also, if the diagnosis is known and you are not planning to give the patient systemic treatment, زي مثلا herpetic uveitis, you can diagnose it just clinically with the typical manifestations and no need for investigation in such patients. كمان مثلا fox uveitis, the same thing. When to test, طبعا anything other than simple anterior uveitis, مثلا recurrent, chronic, granulomatous, bilateral, all these uveitic entities needs workup. كمان to confirm specific diagnosis. مثلا if you are suspecting HLA-B27 anterior uveitis, you can ask for HLA-B27 to confirm the diagnosis. Although you can treat him without doing this test, but as a confirmatory test, you can request this test. أو مثلا CSF in BKH, just as a confirmatory, not to roll out the diagnosis. كمان if there is possibility of certain infectious or autoimmune or systemic vasculitis, like what? Like TB, syphilis, HIV, sarcoidosis, rheumatoid arthritis, all these disease needs to be confirmed by specific laboratory tests. كمان مهم جدا before systemic treatment, you should do basic uveitis workup because you can find some contraindication to certain systemic medications. So as we said, syphilis and TB can present with different type of uveitis. So they are included in any uveitis workup. And syphilis and TB should be screened before systemic steroids and immune modulating treatment, and should be treated if positive. طبعا they can be treated at the same time with steroids, لكن طبعا we should cover the patient with proper anti-infective treatment. We have a big list or a long list of lab tests, but as we said, it should be tailored to and based on your clinical examination and clinical assessment and differential diagnosis. What's the basic laboratory uveitis workup? If the patient needs workup, these tests are usually requested for all أو in all basic uveitis workup اللي هم ال ESR وال C-reactive protein, because they can give you clue about systemic inflammatory process. Syphilis, as we said, because it can present with any type of uveitis and also before systemic treatment. The TB and the PPD plus minus serum quantiferon كمان زي ما قلنا, especially before systemic treatment, till chest X-ray to rule out TB, and sarcoidosis. Also sarcoidosis, it can mimic many types of uveitis, and especially in the high endemic areas, they are screen all patients for sarcoidosis, the African or Western countries. كمان مهم نسوي البيزك workup before any systemic treatment اللي هم CBC والrenal function والliver function والblood level, blood sugar level, because as a baseline, and also because you can find some contraindication or some abnormalities that can modify your treatment. And then if you find, based on your clinical evaluation, you can add some laboratory tests, and this is decided again by your differential diagnosis. مثلا, if you are treating acute fibrinous anterior uveitis, especially unilateral or alternating, you should request HLA-B27 typing, and this is not only to confirm the diagnosis, but also if it is positive, as we said, it means that it can be a sign of another systemic connective tissue disease, especially ankylosing spondylitis or psoriatic arthritis or inflammatory bowel disease. And also, if you suspect TINO, which is tubulointerstitial nephritis with uveitis, which we are seeing here frequently, especially in children, you can request beta-2 microglobulin, which is usually become raised in this uveitic entity. كمان, if you are suspecting juvenile idiopathic arthritis, we should request rheumatoid factor and ANA أو anti-nuclear antibody. وطبعا بالمناسبة الروماتويد factor والANA is not part of our basic uveitis workup. كثير دائما نشوف general ophthalmologist they requested for any type of uveitis. No, it is just only if indicated, like if you are suspecting juvenile idiopathic arthritis, or if you find retinal vasculitis or scleritis, you can request them. And also, if you suspect multiple sclerosis or lymphoma, you can also request brain MRI. طبعا في other laboratory tests, but these are the common laboratory tests that we are requesting other than the basic uveitis workup. This is a long list. طبعا you can read about the possible laboratory test and the significance of each laboratory test. طيب, let us discuss some examples بس يعني to refresh. مثلا, this is 30-year-old female and she came with the sudden drop of visual acuity in both eyes of 1 week duration that was preceded by headache and tinnitus. And when you examine the anterior segment, it was quiet. And the fundus, you see this clinical picture. What are the signs in this picture? Anyone can comment?
الزملاء حد حاب يعلق على صورة الفندس؟ كيف الفيجن دكتور عند المريضة؟
يعني الفيجن نقول انه دروب تو 20 80 اللي او نقول مثلا 6 على 60 in both eyes.
اوكي. او دي سويلنج في او اوبتيك ديسك سويلنج او يو وسبريتال فلويد او يو.
Yes, excellent. So طبعا في some striation which is very subtle here, but definitely there is disc swelling and hyperemia, okay? But there is some striation here that are suggestive of presence of subretinal fluid. So there is disc swelling and hyperemia, and there is faint macular striation. So what's your differential diagnosis? Give me
في
differential
ناس قالوا
diagnosis.
في كي اتش، في ناس قالوا نيورو ريتينايتس.
Okay, excellent. So acute VKH is on top of the list. طبعا في هذه important idiopathic intracranial hypertension, especially انه ما في clear subretinal fluid. فأني disc swelling you should think about it. ممكن يكون malignant hypertension, ممكن neuro retinitis. So what will you do next to aid or to confirm your diagnosis?
نيكست ستيب، اي حد من الزملاء عنده اقتراح؟
any imaging modality or lab test or whatever you want. فتخليك دائما basic، امشي بال common is common.
في زملاء قالوا فندس فلورسين انجيوجرافي، سي اس اف، بلاد بريشر، او سي تي، في كثير.
هو طبعا اول شيء نمشي بال الليس انفيزيف، واللي بيساعدنا كثير انه نتاكد. يعني الان مثلا لو نحط الصوره هذه ل10 ممكن 5 منهم ما ينتبهوا انه في subretinal fluid، اوكي؟ فممكن they will comment on disc swelling, and this is a common mistake. Why I give this example? Because many of the referred cases to us, they are treated at first presentation as benign intracranial hypertension. They come early to the doctor complaining of headache, of tinnitus, and when the ophthalmologist examines them, quickly he sees this disc swelling and hyperemia. There is very subtle subretinal fluid, and he is not aware of it. So he will think, when he join this picture with the symptoms of headache and tinnitus, he will think about benign intracranial hypertension, and he will refer the patient to neurologist. And believe me, some patients, they come to us, they underwent VB shunt, they are on Diamox for a long time, and it is just it is just VKH. So to confirm the presence of subretinal fluid, you should do what first? OCT, okay? So this is the OCT. Clearly there is subretinal fluid in both eyes, okay? Show shallow exudative macular detachment. What other tests طبعا ذكروها الزملاء؟
الاف اف اي وال
Excellent. What is this typical picture اللي تكلمنا عليها؟
الستيري سكاي.
Okay, starry sky appearance أو pinpoint leakage with hyperemic disc, okay? This is very characteristic of acute VKH. طيب, what other findings? What's this?
الزملاء حد عنده إجابة؟
What it indicates? طيب هذه it is pooling of the dye at the area of exudative detachment. Okay, دائما if there is exudative detachment at the late frame of fluorescein angiography, a dye will pool in the areas of serous retinal detachment. So there is pooling of dye in areas of exudative retinal detachment. What other tests, which is not necessary but to confirm your diagnosis?
ما في رد، بس أعتقد دكتور كمان ممكن ندور على الأذر systemic features زي الفيتيلايجو
Okay, this is in the clinical examination. Yes, you are right. لكن في ophthalmic modalities, what doctor?
حد الزملاء كتب MRI.
MRI, I will not agree. يعني with this typical features, OCT and this FFA, for me, no need at all to go for MRI. You just, if you want to confirm your diagnosis, to do ICGA, okay, indocyanine green. You will find these typical multiple choroidal granulomas. So with this clinical picture, I would agree if you don't do any ophthalmic imaging. That is the advantage of our ophthalmic imaging modalities, because if you do this, you find serous retinal detachment, and you do FFA with this very typical picture. No need at all to go for MRI. Okay, so what's the diagnosis?
في هذه الحالة الزملاء، هذه حالة أخرى دكتور صح؟ مش نفس
لا
الحالة.
نفسها.
أوكي، هذه الفيكيتش صح؟
NPH, okay. So depending on the clinical picture and just the ophthalmic imaging modalities, you can reach the diagnosis with certain confidence or with great confidence, without the need of any radiologic or any lab confirmatory tests. Okay. طيب, so all these tests, خلينا نشوف شباب, all these tests can be relevant in this case, except يعني you can order all these, وفي one test اللي هو usually not indicated or not useful. What do you think?
إيش التست اللي مش محتاجينه في هذه الحالة؟ روماتويد فاكتور، أحد الزملاء كتب.
طيب.
روماتويد فاكتور في 3 الآن كتبوا 4 روماتويد فاكتور 5. الكل أعتقد متفق.
ما شاء الله, ممتاز. طيب why pregnancy test is important?
عشان الإيديوباثيك انتركرينيال هايبرتنشن أو شيء ممكن يكون associated ولا أو عشان التريتمنت؟
Excellent. عشان التريتمنت usually طبعا لما نناقش ال BKH usually we give them mycophenolate mofetil, which is highly teratogenic and contraindicated in pregnant ladies, or even in any lady that is planning to get pregnant within 3 months. Okay, so we should request pregnancy test before starting mycophenolate mofetil. Okay, excellent. طيب, نشوف another example. This is 40 years old male presented with floaters and drop vision in the right eye of 4 days duration. The anterior segment quiet, وكان old posterior synechiae in both eyes. The fundus, he has this picture. What are the signs that you are see here?
الزملاء إنه واضح إن في vasculitis وفي hemorrhage.
Okay, so this is vascular sheathing, which indicates vasculitis, active vasculitis, with hemorrhage that is almost along the inferotemporal branch. So this is what? This is retinal vasculitis with inflammatory branch retinal vein occlusion. Okay. So branch retinal vein occlusion can be occlusive or can be inflammatory. If how to differentiate them? By the presence of vascular sheathing. If you see vascular sheathing along the area of branch vein occlusion, this is most likely inflammatory branch retinal vein occlusion. Okay, so differential diagnosis of this case can include all except. What do you think?
طبعا الزملاء أحد الزملاء الدكتور يسلم كتب إنه ممكن يكون diagnosis periphleboitis أو بهجة disease.
طيب, so what will you exclude from this differential?
VKH أحد الزملاء كتب.
طيب, any other suggestions?
multiple sclerosis. VKH.
VKH. طبعا الإجابة الصحيحة هي ال VKH. All these can cause retinal vasculitis, especially Behçet and TB vasculitis, but also sarcoidosis and multiple sclerosis are causes of retinal vasculitis, but VKH never cause retinal vasculitis. Okay, excellent. طيب, about this case or any vasculitis, retinal vasculitis, one will favor the diagnosis of TB vasculitis rather than Behçet vasculitis. ايش الفايندينج من هذه اللي بترجح كفة التي بي vasculitis على البهجت vasculitis؟ هل جرانيلوماز في الاي سي جي، ولا سيفير ريتينال اسكيميا في الاف اف اي، ولا ماكلر ايديما في الاو سي تي، ولا if you see multiple foci of retinitis في الكالر فاندس فوتو، ولا if you see demyelinating lesions in brain MRI. one of these.
أيوة. لحد الآن 4 جاوبوا A granulomas on ICG A.
خلاص, طبعا أتفق بقوة. excellent. So Behçet is non-granulomatous disease or uveitis. So طبعا قلنا granulomatous مش شرط إنه تشوف كيراتيك متنتات كيراتيك بريسيبيتيتس، لا. إذا شفت iris nodules، إذا شفت angle nodules، إذا شفت granuloma in the blood vessels or granuloma in the choroid, this is granulomatous uveitis, and Behçet is non-granulomatous uveitis by definition. So if you see granulomas in the ICG, طبعا on the top of the list اللي هم TB والsarcoidosis والVKH. severe retinal ischemia, طبعا TB والبهجت are well-known causes of severe retinal ischemia in fluorescein angiography. Unlike MS والsarcoidosis. عادة MS والsarcoidosis can cause vasculitis, but usually it is not ischemic. Okay? Macular edema can occur with any type of vasculitis or uveitis. Presence of multiple foci of retinitis, actually this will favor Behçet uveitis. If you see multiple whitish spots of retinitis, this goes more with Behçet uveitis. طبعا demyelinating lesion هذه goes with what? With multiple sclerosis. طيب, in non-granulomatous anterior uveitis, all can be reasonable tests except, يعني كل هذه can be justified في your workup of non-granulomatous anterior uveitis ما عدا واحدة useless أو ما لها داعي مثلا.
الزملاء من عنده إجابة؟ ممكن تكتب فقط رقم الإجابة A أو B أو C أو D و E.
Yes.
أوكي, في معنا إجابة C.
أوكي.
وفي إجابة D. وC مرة ثانية، C مرة ثالثة، 3C 1D.
حلو, خلاص أنا مع رأي الأغلبية. excellent. So anti double stranded, طبعا هذا نستعمل ال SLE أو systemic lupus erythematosus, which is very rare can present with anterior uveitis. عادة تجيب vasculitis, تجيب scleritis, تجيب choroiditis أو choroidal effusion. But anterior uveitis is not typical manifestation of SLA. HLA B27 in the top of the list, beta 2 microglobulin, especially in bilateral non-granulomatous uveitis in children. Always keep it in mind. Here we have many cases. يعني we have at least 40 cases, كلهم proven by renal biopsy to have tubulointerstitial uveitis and nephritis, and most of them be present with bilateral non-granulomatous uveitis. If you see this, you should request beta 2 microglobulin, which will be high. Syphilis قلنا it is part of any uveitic workup. A.N.A. طبعا if I told you it is an adult, I would agree about anyone who will exclude this. لكن لأنه ما حددنا A.N.A. is only indicated in juvenile type of non-granulomatous anterior uveitis to rule out what? To rule out الjuvenile idiopathic, أو to confirm, not to rule out, to confirm الjuvenile idiopathic arthritis associated uveitis. Okay. طيب يمكن آخر سؤال. In Behçet uveitis, all these can be useful tests except.
تمام. السؤال إنه كلهم مفيدين في بهجت ما عدا واحد غير مفيد. أوكي. في إجابة E وإجابتين C.
اوكي.
3 إجابات C. 4 إجابات C.
طبعا ركز على الستيم. useful مش mandatory, can be useful. فمهم جدا هذا الترك في السؤال. معنى هذا انه إجابة C خطأ. طيب فبعطيكم فرصة ثانية. يلا.
الزملاء إجابة أخرى. دي أحد الزملاء جاوب دي، مش عارف.
طيب خلاص. طبعا الإجابة الصحيحة الإي. طيب HLA B51, although it can be associated with Behçet, but it is highly non-specific and highly not sensitive. طيب في studies تقول sensitivity is only between 30 to 60%, and also specificity يعني normal population up to 18 to 20% of normal population can be positive for HLA-B51. طبعا احنا نتكلم على our region. It is useless, and even worldwide it is not part of your workup. Maybe in certain geographic areas, especially Turkey, عندهم studies they link this in up to 60 to 70% of uveitis cases, of Behçet cases to be positive. Like in other regions of the world, it is not specific at all, and the association is very low. So, to cut it short, even if it is positive, this will not confirm your diagnosis, okay? And if it is negative, it will not rule out your diagnosis. The brain MRI, sometimes it's very important because Behçet can present with vasculitis. And especially in certain, if you are planning to give patients biologics, some biologics they can induce or exacerbate brain vasculitis. You should do this if you are planning to put patient in certain biologic treatment. Okay. فالإجابة هنا اليوزلس اللي هي الإي. دكتور ما أعرف الميديكال مانجمنت طويلة شوي، فهل تقترح أنه نكتفي بهذا القدر ونخصص محاضرة أخرى للمانجمنت اوف يوفيتس؟
ما في مشكلة دكتور، بإذن الله. تمام.
يعني almost 1 hour. yes.
Yes, exactly 1 hour. احنا ممكن نترك كده بعض دقائق للزملاء اللي عندهم إضافات أو أسئلة. أعتقد المحاضرة كانت رائعة جدا، الله يعطيك الف عافية. يعني غطيت موضوع الانفستيجيشن بشكل رائع. هفتح طبعا المايك الآن للزملاء اللي حابب يعلق فيه.
السلام عليكم.
عليكم السلام، أهلا دكتور خالد، حياكم الله.
حياك الله، شكرا جزيلا دكتور عبد السلام، شكرا دكتور عمرو، شكرا مركز نور اليمن للمحاضرات القيمة هذه، شكرا جزيلا لكم. حقيقة عندي استفسار أو توضيح. يعني بصراحة أنا ما حضرت السيشن الأول، لكن من خلال from practical point of views عندنا في العيادات، يعني معظم الحالات اليوفيتس اللي فعلا يعني تحتاج تركيز عليها هي anterior uveitis، ونعمل لها كل الفحوصات ومعظمها بتطلع نورمال. طبعا بالنسبه للانتيريور يوفيتس هذه اللي نشوفها اكثر حالات اللي تجينا انه تكون بعمر بالذات بالفيميلز من تقريبا من 20 الى 35 years ago. يعني تجي تيبيكال انتيريور يوفيتس رياكشنز ساينيكيا early cataract بين يعني complications or signs of symptoms of anterior uveitis. When we do workup for their all normal, no بهجت, no even يعني بالexamination no infective issue بالموضوع. يعني I think it is يعني idiopathic أكثر حاجة بتجي عندنا، خصوصا بالفئه العمريه هذه. بتجي عندنا انتيرير يعني الانتيرير فايتس مع سينيكيا مع ايرلي كاتاراكت، وحقيقه annoying يعني cases. sometimes we stop we can't do anything for them, just we treat the acute يعني we treat the acute stage by treatment, it will resolve. But the chronicity of the condition, synechiac, early cataract, annoying pain, recurrency, it is always we see in these cases. My question is, يعني how can we deal with this patient from your point of view? How to prevent these complications, how to deal with cataracts, especially we can't do by examination all things are normal. This is my questions because we face a lot of cases in our clinics. شكرا جزيلا دكتور.
طيب الله يعطيك العافيه، شكرا جزيلا دكتور خالد. you are right. طبعا حتى worldwide الانتيريور uveitis is the most common، وكمان among the anterior uveitis the most common is the idiopathic one. Okay, but I totally agree إنه most of our workup of anterior uveitis will yield no results. We diagnose them only as idiopathic anterior uveitis, especially if non-granulomatous. If granulomatous, this is something else. If granulomatous, you should find a cause. Okay, if you see mouton fat KPs, especially viral. Viral is very important, especially at this age group. If it is unilateral, at the same eye always, and you can find some granulomatous or pigmented keratic precipitates, you should think of viral, especially herpetic, and sometimes you need to treat them with antiviral. الآن other non-granulomatous uveitis at this age group, from our practice اللي هم non-idiopathic, the most common HLA-B27. Okay, I don't know if you are doing HLA-B27 typing أو في facility to do it، لكن إحنا هنا بنسويه، وطبعا في عندنا good percentage of patients they will be positive for HLA-B27. وحتى المثير في الموضوع انه ممكن اليوفيتس can precede any systemic symptoms by years. يجونا مرضى they are just complaining of the eye when we ask them about low back pain, about skin changes, about altered bowel habits. They deny any systemic complaints. بس نيجي نسوي ال HLA-B27 يطلع بوزيتيف. طبعا هنا احنا وي ار لاكي انه عندنا مالتي ديسيبلينري كلينيك، يعني عندنا روماتولوجي كلينيك وعندنا at the same setting and we are in collaboration with each other. If we are suspecting any systemic connective tissue or autoimmune disease, we refer them and they kindly accept these cases. So we refer such cases to them and they do some like MRI, lumbosacral joint, and this imaging can detect very subtle changes that precede the X-ray finding or the systemic findings. فمهم بالنسبة لي إذا تقدروا تسووا ال HLA-B27 تايبنج. إذا والله ما في possibility لا حول ولا، بيظل الواحد يعتمد بس على لما يطلع مع المريض systemic complaint of back pain أو skin changes أو altered bowel habits. إذا لا خلاص you can treat with as idiopathic. طبعا when to investigate قلناها قبل شوي. if recurrent خلاص you should investigate. اوكي، يعني المريض يجي دائما كل شهرين ثلاثة يجي معه uveitis, you should investigate such cases. If you don't find, you can treat with idiopathic. Idiopathic بنعالجهم عادة topical، وطبعا topical أحيانا we maintain the patient on long-term prophylactic dose of steroids topical، يعني sometimes twice a week or once a week نعطيهم قطرة، و many of them they remain quiet. أو أحيانا especially في children you should give systemic treatment and especially في ال HLA-B27 عادة تيجي بسevere fibrinous anterior chamber reaction and حتى مرات بvitritis و sometimes not responding to only topical، فنعطيهم systemic steroids short course for 1 month half dose half الادلت دوز، يعني إذا وزنه 70 نعطيه 40 إلى 35 وكل أسبوع يشيل حبة. المهم within 1 month و many of them they will improve. أو you can give local if you don't like to give systemic, you can give local like subconjunctival or I will not recommend the intravitreal steroids unless you are quite sure that this is not infectious. الشيء المهم الأخير اللي عرجت عليه حضرتك اللي هو الكاتاراكت مانجمنت. طبعا مهم جدا ال preparation of patients with uveitis for surgery. لازم، وطبعا ال guidelines إنه ال patient should be quiet for at least without treatment or on treatment for at least 3 to 4 months. Okay. فأنا for me it is a crime to operate a patient with active or recently active uveitis. Many of them they will develop very severe inflammation that you cannot deal with post-op. Many of them they end with ocular hypotony, chronic hypotony and lost eyes. فمهم جدا إنه ما تسوي أي عملية، يعني you can postpone the patient but better than lost his eye. تعطيه good treatment especially perioperative، تعطيه أول أو قبل العملية بأسبوع أسبوعين frequent steroids like every 2 hours. حتى if you are in doubt you can give him additional anti-glaucoma if you are يعني afraid of high IOP. Sometimes we give patients pulse steroid therapy. We admit such patients, we give them IV methylprednisolone 1 day pre-op and at the day of surgery and 1 day post-op. Okay. فضروري جدا إنه don't operate any eye with active or recently active uveitis.
شكرا. ممكن سؤال آخر لو سمحت دكتور؟
تفضل.
شكرا دكتور، إجابات قيمة. كنت أشتي أسألك دكتور فيما يخص البروفلاكتيك لونج تيرم تريتمنت. Is it better to give low dose steroid or better to give azathioprine also in the low dose? Thank you.
طبعا if it is purely anterior uveitis and it can be controlled with low dose، هو ممكن نعرج بعدين على اليوفيتس لما نتكلم عن التريتمنت. في جايد لاينز انه if you can maintain the quietness of the eye with one or less than drop per day، يعني لو المريض يظل quiet على single drop أو أقل every other day, so no need for systemic treatment. Okay, but if the patient not be quiet unless you give him like TID or QID a day, in this case I will agree with you that you should give him other systemic treatment.
شكرا جزيلا. هل في أي استفسار آخر عند الزملاء؟ ممكن نكتب على الشات بوكس أو أي أحد حابب يفتح المايك. طيب شكرا جزيلا دكتور عبد السلام، جزاكم الله خير، محاضرة قيمة جدا. في سؤال على التكروليمس، أعتقد ممكن لما نيجي للمانجمنت هنتكلم عليه. دكتور عبد السلام.
أي نعم. Okay, what's the question? If I can.
Dose of the tacrolimus will role in treatment.
Okay, well, to be honest, we are using الcyclosporine طيب, which is the same family اللي هو T cell inhibitors. We are using الcyclosporine, with dose of cyclosporine we are using it 5 milligram per kilogram, okay? BID أو twice a day. لكن tacrolimus I don't have experience with it.
أعتقد يعني تكروليمس أكثر مثال مشهور فيه الاستخدام التكروليمس اوينتمنت في حالات البي تي سي.
exactly severe أو حتى مرات في السيفير dry eye، بس البيرنال كاتاريس it can be used. لكن كسيستميك yes في some they use it، واحنا we are not using it just because of the availability. Okay, they are not approved أو تكريمس was not approved. عندنا لجنة طبية لازم يوافقوا على أدوية معينة للعيون أو لكذا، يعني unfortunately it was not approved. That's why I don't have that experience in using tacrolimus. لكن لما نيجي على المحاضرة ممكن نشوف what is written in the literature about it.
الله يعطيك مع الدكتور. طبعا أحد الزملاء بيسأل على المحاضرات كلها متوفرة على اليوتيوب على قناة مركز نور اليمن، بتنزل إن شاء الله خلال أيام. طيب شكرا جزيلا دكتور عبد السلام، وبانتظار المحاضرة القادمة إن شاء الله. الله يعطيكم ألف عافية وجزاكم الله خيرا، وشكرا للحضور جميعا. الله يعطيكم العافية.
شكرا دكتور عبد السلام، محاضرة رائعة جدا.
حياكم الله.
شكرا عمر، دكتور عمر، شكرا مركز نور اليمن.